I'm really happy to introduce Sean Valles, who's one of the leading thinkers in philosophy and medicine, and he's written a book which is excitingly relevant, or at least the philosophy of population health. He's an associate professor at Michigan State University, and will talk to us about, for an anti-racist medical education, students must learn about the full range of racism varieties, not just interpersonal bias. All right, brilliant. Thanks, Sean, for joining us.
Thank you very much. Sorry, can everyone see everything? Can hear me? All that sort of thing. Yeah, sorry, it's and please forgive me if I sort of like moved the screen around a little bit. I'm recovering from surgery on my ankle, so everything is uncomfortable, so I kind of have to like move around a little bit. What a year, huh? Okay. So this is actually very helpful timing in a certain sense, since the previous presentation actually went over much of the same ground I want to try to cover too, which I think is a good thing. So I'll try to do my best to basically provide a complementary perspective to the wonderful last presentation. I thought it was awesome. So earlier this year, I wrote a paper on what I call the predictable inequities of COVID-19, and I'm sort of I'm thinking along the same lines here, because I'm also infuriated by those politics of surprise, as it was put. So I'll try to not to repeat too much, and I'm also going to work towards talking about humility towards the end, and along the way, hopefully, I'll be able to address some of the previous questions that came up in the last session about interdisciplinarity and how to sort of move forward from here without thinking exclusively biomedically. So I will jump right into it. So I think it's a wonderful thing that we actually are sort of getting some sort of international momentum on basically calls for getting some attention to discrimination and racism inside healthcare. I think it's a wonderful thing. There are sort of endless articles, op-eds written about it. The thing that I find that I can find frustrating in the process is that in the United States, especially, although I see it in the discourse in other countries, including England as well, there's a tendency towards trying to reduce as much as possible racism to interpersonal interactions, and that's a very narrow view of what racism is or could be. So concerns about things like implicit bias in interactions between the patient and the patient towards the caregiver towards the patient between other patients, and how they interact with other patients, caregivers to caregivers. All these sorts of things are very important, but that shouldn't be all that we teach inside medical education. It shouldn't just be about these sort of individual decision-making kinds of things. Frankly, there are more facets to racism than that. I'll elaborate on those in just a moment. So interpersonal racism is sort of the easiest one, but there's also structural racism, and one that's rarely talked about at all inside these contexts, which is internalized racism. So I'm going to try to sketch out some of the sort of causal and epistemic considerations that are relevant here, and sort of thinking about what are sort of the features of racism that we should be aware of as we're trying to move forward on an effective anti-racist medical education, because I do think we need such things. It's really going to be a lot more complexities, and I'm not going to be providing a sort of a curriculum to you, although I will point to a couple along the way. So the framework I use for understanding racism originally comes from Kamara Phyllis Jones, who is the previous president of the American Public Health Association. And I like this diagram because it's relatively simple, and I think it illustrates more or less the full extent of the pathways through which, or the types of pathways through which racism can manifest. So we're all relatively familiar with personally mediated racism, so interpersonal racism, discrimination, bias. You treat one person in a way that is different from the way it ought to be based on whatever sort of criteria you want to use. Although she also points to things like stress, and so it's a growing area of essentially biomedical research looking at the direct effects of discrimination, such that basically being subjected to, especially repeatedly over the course of a day and throughout a lifetime, being subjected to discriminatory treatment basically puts one at sort of like a heightened stress level permanently. and that the cumulative effects of that kind of stress level causes what's called weathering on the body, and it basically just sort of deteriorates your body relatively quickly. It ages you, among other things, more quickly than your chronological age would indicate. So all of that would sort of fall under personally mediated. There's also finally more and more attention to institutionalized racism, and so that's been in sort of every to every news source that I've seen, much more this year than in previous years, which is a good thing in a lot of ways. So socioeconomic status and access to various resources and housing and treatment by the police, and whether you live in a neighborhood that is aggressively policed, all these sorts of things all go into it. A lot less attention is given to things like internalized racism, and so there's often this dichotomy between individual behavior versus anything having to do with racism, and it's weird because it's sort of operating under this presumption that basically every member of a minority population, of a minoritized population that's been marginalized, will sort of immediately recognize racist ideology as being false and not appropriate for them to believe, when it is in fact the purpose of racist ideology to try to convince people from marginalized populations that they are not deserving of whatever resources. And so for instance, when my father was told that he would be disowned if he went to college because it was racially inappropriate for him to enroll in college as a Mexican American, like that was sort of stepping outside of his proper role, and he had a social role that did not include a higher education. So these kinds of things are so we need to address we need to think about how individual behavior is not somehow sort of carved off from racism. So this goes into everything like diet and housing and all sorts of other behaviors as well. I can talk more about that later. That's sort of a whole other talk. So as before, I am also interested in sort of the peculiar discourse around around the horrible inequities of what's happened to NHS staff and minority staff in particular. So it was really interesting, and in a very frustrating way, seeing the sort of the progression of how that played out. So first there was noticing that it was existing in the first place, and so NHS deciding it was going to review if ethnicity puts some healthcare staff at higher risk. I'll come back to that idea that if ethnicity puts you at risk of higher risk. Then trying to do some sort of pivot to try to find means of actually trying to reduce those risks, and eventually having that manifest in terms of actually a set of different methods and tools. One of the most widely used ones is the safety assessment and decision risk tool, which essentially tries to identify which Black and minority ethnicity, and I know that term is very controversial, so I'm using it in quotations here. I know it's been divisive inside the literature and inside the communities, because it's agglomerating in a way that can be very problematic. Trying to cash out the net additional risk that would be happening by doing things like scoring someone's ethnicity, such that if you are Black, then you have 4 points of risk, as opposed to if you're Indian, then it's 2. This is ethnically, and then combine that with age, whether or not you are pregnant, body mass index, etc., is sort of factored in as well. And so this was well intentioned. What's interesting to me about it is how it addresses certain aspects of racism and avoids other ones. So the thing is, as that headline put it before, or contrary to that, it's not as if ethnicity puts someone in a risk population. It's racism that does. And so I think the first thing that sort of needs to be sort of drilled into the heads of medical students and students more broadly is that when we're talking about racial health disparities, I think it's actually more helpful to talk about things like racist health disparities. I think we need to really foreground racism here, because otherwise we run into that problem that was brought up before, which is that we start thinking of we start thinking of these of basically these sort of disparate health experiences as being somehow inherent or coded into being a part of a certain race or ethnicity, when in fact there's never been any evidence that this could be the case. So that checklist approach is a really interesting one in terms of trying to find a way of having essentially managers inside healthcare institutions to try to assess and reduce the risks of their employees. But the thing is, though, the existing understanding of racism, in the sense of these are not new concepts, it basically has a lot to say about why that checklist was not an especially promising way of actually trying to accomplish that goal. So a checklist and the possibility of being reassigned to do desk work, for instance, instead of patient care, based around that score, that's built around the presumption that healthcare leaders are actually willing to devote extra resources into valuing and protecting their minority staff. But the thing is, though, a relative lack of concern, whether intentional or unintentional, and a devaluing of those staff through various different means was always one of the most plausible reasons for why that disparity emerged in the first place. And so it's essentially asking managers to care their way out of not caring enough about their staff. And so what we end up with, for instance, is that once the tool gets implemented, once the tool gets created and sort of sent out into the world, it's only if the staff managers actually do care that they actually use the tool in the first place. And it's also not going to address things like the fact that that Black and minority ethnicity, again, like quotations, nurses feel targeted to work on COVID-19 wards, as in they're intentionally being put there, or at least knowingly being put there. And it's and having some sort of risk score that says that, oh, it's your BMI that is making you at higher risk here. That's not going to address the fact that that it seems to be that the way the NHS has been structured in a broader way has made it such that access to necessary PPE in order to actually have any kind of personal safety has been relatively scarcer among minority staff. So first of all, this sort of model of relying on that sort of risk score, it relies on caring interpersonal relationships when it's the absence of those caring relationships that's going to be part of the problem. That's something that needs to be built, not just presumed to exist in the first place. Second of all, that sort of risk score it digs into the biological features like BMI. It's trying to really find out like what are the particular mechanisms by which this actually matters. And so it's very attentive to the nuances that exist on the biological side, although the features like BMI are actually quite contested. But it really entirely avoids in a really conspicuous way digging into the similarly relevant structural and institutional sorts of features that are also important here. So it doesn't ask any questions about whether or not one is going to struggle with having enough food or housing in the case of illness. And it can't really do anything to address the fact that it's already pre-existing occupational patterns that disproportionately put minorities in clinical roles that are lower status, such that lower status involves more hands-on patient contact and hence higher number of risk exposures. And so that relates to the structural features at play. And then interestingly, the model does have some sort of indirect and not insignificant way of addressing the problem of internalized racism, although it doesn't really have a solution for it. So it's a very difficult problem that minority healthcare workers, just like anyone else, are going to be susceptible to believing that they actually should be the ones that are taking on those higher risk roles. And so if one sees it as essentially the role that is played, that one plays inside healthcare, such that they have to do that they do the patient care, whereas the white male doctor does the supervisory roles that are lower risk ones. It's hard to sort of get out of those social roles if people just really on either end essentially endorse them in some way or another, whether consciously or unconsciously. So it helps to have some sort of more objective criteria for sort of pointing out to someone that they are at high risk. But on the other hand, it's not really actually addressing the problem of internalization. And I just want to point out this is not just isolated to the NHS. So for instance, there's been some recent work in the United States pointing out that especially Filipino American nurses have had a far disproportionate harm inside U.S. healthcare institutions. So they make up a very small proportion of U.S. nurses, but the number of the mortality has been hugely more disproportionate, afflicting them. So one of the things that interests me here is there's a bit of a tension that I think needs to be addressed. So on one hand, there are these sort of population level trends that we see, things like these patterns of U.S. racial disparities and COVID-19 deaths, and so you can see that Black Americans are dying at slightly higher rates than Indigenous Americans, who are dying at substantially higher rates than Latinx populations. Slightly higher than the Pacific Islander populations, higher than white populations, and then Asian populations. And so there are these disparities, and there are reasons for them. A lot of it has to do with the proportion of that population that are able to do telework as opposed to in-person work, because of the horrendous ways that the U.S. has sort of managed or not managed those kinds of workplace risks. So on one hand, there are these sort of population level trends. But then on the other hand, there are the sort of the more familiar biomedical trends that's where we sort of know from all sorts of other contexts, including inside COVID-19, that there are individual patient level risks that are at play here. And so we know that genes matter for certain things. We know that family history matters for things. We know that individual behavior matters for things. And so how do we sort of square the existence of these population level trends with these individual level risk factors? This sort of intuitive move, and this is used quite often inside the literature, is to presume that some of those individual risk factors are the ones that are causing these things. And so are there genetic reasons why this population or that population that's has this ethnic or racial population has a higher rate of infection or death, whatever the thing is, from COVID-19 or any other kind of factor? The thing is, though, there's actually been this is a question that's been answered before, and it's so this is a distinction that the epidemiologist Jeffrey Rose made first in 1985, and he elaborated in his book. And what he pointed out is that we actually need to separate these two different kinds of questions, and it's gonna be helpful for us to understand sort of the nature of the causation of these kinds of disparities if we are able to sort of carve apart different kinds of questions that are relevant here. So on the one hand, we can try to look for the causes of the individual cases. So causes of basically what makes this one patient ill, and this other, as opposed to not being well. And on the other hand, we can look at what is causing disparities between populations. And so it actually turns out it's going to be a very different question, trying to ask what is causing this individual patient to have heart problems, compared to why are there these large disparities between, for instance, cardiovascular disease rates between to Black Americans versus white Americans. So, for instance, there was a wonderful paper that was written in 2015, I believe, by Kaufman et al. And they pointed out that we've done a massive amount of research on the genetic factors that are related to cardiovascular disease risk, and those individually and cumulatively are quite substantial in basically differentiating between which of us has higher rate of cardiovascular disease risk. It can be related to all sorts of different aspects of it, or even just more generally. On the other hand, if we try to see if any of those map onto into the population level disparities that exist between Black Americans and white Americans, they don't match up at all. And so basically those two trends of individual level risk factors, including genetic factors, matter quite a bit. And there are also disparities between populations. They both exist at the same time, but they are not attributable to each other. They're just two different issues. And so on the one hand, my individual risks are going to be highly contingent on my genetic risk factors and some other individualized matters, but that has nothing to do with the fact that Mexican Americans have much higher rates of diabetes than white Americans, or than non-Hispanic white Americans. And so basically that's what Kaufman et al. Helpfully did, sort of showed quantitatively that there basically was no overlap at all between these factors. It's helpful for sort of differentiating between those and saying that those genetic factors or whatever individualized factors are separate from the population level factors. And that's important for when we're thinking about excuse me, there we go, how to understand the structure of racism as a health harm. So the thing is, we can't build up an understanding of racial health disparities by digging into data of patient level risk factors. So we can keep doing studies of the population genetic distribution of loci that are associated, genetic loci with heart disease risk, but we already have a lot of evidence that that's not going to do anything to understand the racial health disparities. We're going to have to deal with those population level effects by actually looking at the population level factors that are relevant here. And so for this purpose, I like to rely on what's called the fundamental cause theory of health and disease. So this is proposed by Lincoln Phelan in 1995 in an attempt to really synthesize together sociological understandings of health with epidemiological ones. It's basically it's both epidemiological and sociological as a contribution. And what they wanted to point out is that we can try to understand the way that something like money or power or prestige has an enduring effect on health across time, across generations, even across social context. And so it is helpful to have extra money, almost regardless of what kind of context you're in. And so so for instance, like in the United States right now, it is a very, very helpful health protecting feature to have enough money to be able to pay for grocery delivery, as opposed to going to a grocery store when at the moment the country has basically extremely weak procedures for actually having things like using face masks or having any kind of sanitation procedures inside businesses. And so it's a giant surprise that ended up being such an important health protecting feature. But it was but the fact that having money is going to be helpful with dealing with a pandemic or whatever sort of health challenges emerging that year is not a new thing. And so that's what fundamental cause theory is trying to get at. And so what it points out is that resources are flexible, so that their presence or absence is going to affect a lot of different health outcomes through a lot of different mechanisms. And so even though which sort of particular things are sort of like most looming in a particular year. So for instance, rates of opioid use go up and down inside the United States. At the moment, they're at a high point. Rates of particular infectious diseases go up and down. At the moment, obviously, we're in the middle of an especially high one. That might be the case, but there are certain resources like money, power, and prestige that are going to be helpful across those different contexts. And so money is going to help you pay for healthy food if prices go up after a drought or during a pandemic. It'll let you move to a new neighborhood if you discover that your water system, that your water supply is unsafe, and so on and so on. It's the fundamental causes or the absence thereof that make what Froelich and Potvin call, it makes you vulnerable to being at risk of risks. Applied to racism, well, racism also functions as a fundamental cause, and it should be addressed as such. So, for instance, there's a common conservative political argument that if we remove legal structures of racism, then it should eliminate any kind of racial disparities, including health disparities that were resulting from that effect. So, for instance, in the United States, it took us quite a while to gradually, and it still hasn't entirely happened, remove the structures that allow overt hiring discrimination against racial and ethnic populations. And so even if we remove those legalized means of having like outright hiring bans where we refuse to hire people from this population or that population, well, that obviously leads to things like low income, worse housing, etc. And so it can manifest in all sorts of different ways. But the thing is, though, because of the nature of racism as a fundamental cause, it's going to be the case that it's going to continue operating even across different contexts. So if you change the context so that essentially you're sort of cut off one head of the hydra, such that hiring bans are now illegal, well, what you get instead is just you have covert hiring discrimination that's been empirically demonstrated in the United States. It actually appears to be either stable in its effect over the last few decades, or actually might even be increasing in terms of employer preference for white versus black employees in particular. Might be slightly decreasing for Hispanic people like me. So racism is going to keep manifesting in new ways using new mechanisms as society changes. So we can be confident that racism will continue to manifest new harms via new mechanisms until we actually address the root fundamental problem. And so we can't just sort of cut off these sort of single manifestations without addressing the underlying problem. And it's not always going to be limited to just socioeconomic patterns. So it could also be things like access or influence on powerful politicians. Do the politicians who nominally represent you actually care about you? If they don't, then that leads to low social power, and you lead to effects like far disproportionate policing of some neighborhoods versus other neighborhoods. A pattern that seems to be the case in both the UK and the United States, among other places. So I think it's really important to foreground racism here, and racism in its sort of full range of effects. And so one thing I try to point out is it is possible for something like a genetic factor to play some sort of role in an average disparity between two racial or ethnic populations. So if you want to point to like Tay-Sachs disease among Ashkenazi Jews, or if you want to point to sickle cell anemia among Black populations in the United States versus white populations, although sickle cell anemia is far from a Black disease, it has a lot more to do with ancestry in populations that are exposed to malaria, which is entirely different. So I think it's a false dichotomy that we have to either sort of acknowledge, we have to refuse to acknowledge the existence of genetics as having any sort of influence on anything ever. But the important thing is that even if there are some number of features that somehow are disparate across two different racial or ethnic populations because of something that is more innate, like a shared genetic trait, if on average. It's essentially a red herring in the sense that none of those things can even possibly compare to the scope of the problem, such that, for instance, American Indians and Alaska Natives die about 5.5 years under the U.S. average. And so when people say, oh, but there are genetic factors, or there's some of these other things that are not related to a society structured around racism, well, that may be the case, and how big this little dot is a matter of dispute. I think it's probably actually smaller than that proportionally, but it's sort of hard to represent that sort of thing. But that doesn't address the fact that the scope of these disparities, that minority staff might be dying at several times higher rates than white staff of COVID-19. None of them are even in the same ballpark of what we're actually talking about here. So I think it's important to sort of like acknowledge that that some of those effects do exist, like that blood type seems to have some sort of effect on COVID-19 risk, and blood type is not evenly distributed across geographic populations. But sort of that fixation on it is essentially a red herring. So what do we do about this? Well, one particular model that's been used, and there is actually a full curriculum that's been made available online by METZL. I'll give the citation in a minute. Is what in the United States became called structural competency, and it's made some headway over the last few years. It was proposed in I think it was first proposed in 2014. It had been sort of bubbling up since before then. And what the idea is that a physician, or arguably nurse, or other healthcare professionals is actually not fully competent until they understand how their patient care fits within a larger structure of society. And so if they're not aware that, for instance, that there's their patient's ability to actually take the medication that's been prescribed to them due to their access to transportation, to having enough money to pay for it, their ability to receive time off from work, these sorts of things. And so it's I think it's meant to be provocative in the sense that it says that that until a physician actually understands something about the sort of the inequitable structure of the world, or the structure of the world just more broadly, but it happens to be extremely inequitable, then they're not actually going to be competent to care for patients, because if basically their vision is limited to what's happening inside the clinic walls, then they can't actually do good patient care. They're not going to be effective caregivers. And so there have been attempts to try to actually implement this inside particular medical schools, and the results are sort of encouraging but also frustrating. And so for instance, teaching this to medical residents, it sort of brought a combination of feelings of empowerment. It's like, oh, I feel like I can really finally understand and do something about this, but then also realizing, oh, but like, what actually could I do about this? So for instance, residents stated that the training had a positive influence on their relationships with patients, and so they felt like they could really like understand their patients more fully and help them to build a partnership. I'll come back to that in just a moment. And also they felt overwhelmed by their increased recognition of structural influences on health. So they expressed the need for practical strategies to address structural vulnerabilities in and beyond clinical settings. And so good for them for realizing that, yes, this is going to be extremely difficult. So again, I'll come back to that building a partnership in a moment. So it's, in some sense, it makes things harder before it makes them easier. And so if we actually want to start having something like an anti-racist curriculum, it's going to include a need to actually understand how things like policing and food security and economic inequity and all sorts of other features and colonialism all sort of structure the world within which patient health happens. But it's going to be extremely difficult and frustrating to actually start recognizing that formally and thoroughly inside curricula. And so the point that's been made, the point that's been made inside a lot of the American context, and this also shows up inside some of the European context where some of these ideas emerged, is that we need to start recognizing that health is basically that health promotion requires that we have action across the whole of society. So it's not just that medical caregivers need to provide the best possible care according to the best evidence-based medicine medicine evidence and yada yada yada. All of that's very controversial in and of itself, but that we need to make sure that we have transportation and housing and equitable policing and all these sorts of other features of society that's in order for it to actually have a world in which people can live healthily. So sometimes that's called health in all policies approach. But the one I want to talk about more here, just because I want to sort of highlight some of this because it addresses some of the questions before about what kind of framework would we use for actually trying to do this, because sort of pointing out the criticism is all well and good, but sort of what are we supposed to do about it? Well, the one that I've written about the most is what's called a population health approach. It sometimes calls itself the population health science approach or the population health framework. There are a bunch of different names for it. But basically, Rose, the person who came up with that distinction, or sort of really illuminated that distinction between causes of cases versus causes of incidents, that sort of what's causing two different patients to be different from each other versus two different populations. Well, he was sort of a pivotal figure in actually creating this population health approach, where it sort of emerged in Canada initially, where with this volume asking why are some people healthy and others not, and eventually turned into an entire framework that as Keyes and Galea put it, is a research program that confronts the structural forces. So thinking about structural racism, et cetera, that place individuals at risk, that creates distributions of health and disease unequally across socially defined groups, and focuses on embedding pathways, biological pathways within social interactions that develop across the life course and across generations. So this has turned into a whole scientific and conceptual framework based around the idea that we should foreground the disparities between populations, including racial disparities. And then we need to start thinking about the many ways that those disparities came into being. Link of Lincoln Thalen was one of the presidents of the Maine Society for Population Health. And so these are also to tie together. And then the question is, what can we do about those things? As before, during the introduction, I mentioned that I wrote a book on this, and so I basically try to lay out what I think is sort of the philosophy of population health that I think is sort of nascent inside, or sort of largely unspoken within the field, and why I think it's generally a good thing. I want to mention it here though, and I'm going to try to sort of to try to give a little bit more attention to this because of the connections to humility that are brought up before, because I'd like to sort of to amplify and contribute to that. So I end the book by saying that I really think it's something like the mortar that holds together this population health framework philosophy that sort of exists within the field and within that approach that's been written about since the 1990s. I think it's humility that's really holding it together, and particularly epistemic humility. There are a few reasons for that, and I can elaborate on how it ties together with interdisciplinarity, for instance, more during Q&A. But I want to highlight here that it includes this epistemic humility is manifested as an orientation towards building and synthesizing knowledge. I see that as being sort of built into the field, although it hadn't really been discussed within the field. It's actually the part of the book that sort of got the most uptake within the field itself. Sort of this idea of humility sort of really seemed to resonate, which was sort of my hope. So when I say epistemic humility, I mean in a very particular way, because there are different ways of cashing it out. So my preferred way is the one that was articulated by Anita Ho. And so the way she puts it originally inside a patient caregiver context is that epistemic humility is a disposition as well as a commitment. It arises out of professionals' acknowledgement of the boundary of their expert domain as well as their fallibility. It means a commitment to make a realistic assessment of what one knows and what one does not know, and to restrict one's confidence and claims to knowledge only to what one actually knows about his or her specialized domain. In particular, and I think this is important, it's a recognition that knowledge creation is an interdependent and collaborative activity. Both the healthcare provider and the patient are counting on each other in investigating a full picture of the patient's experience and in determining the most appropriate management strategies. So the notion of building a partnership with patients is very much in line with the position that she's taking on epistemic humility. It's how she manifests what is ultimately a feminist approach to clinical encounters. Or in other words, epistemic humility is not just about restraining one's ego. It's about building knowledge with others, whether it's the patient with experts from one area of science, or whether it's two different experts from different areas of medicine. And that collaborative building process begins with recognizing the boundaries of one's expertise, that we are all each are sort of fallible and limited in our ability to understand. I want to address a sort of one objection here, because there really is quite a split in how people can sort of can interpret what the meaning is of epistemic humility. Jose Medina expresses a very valuable objection here, the one that I hear repeated from especially from scientists and physicians as well, about basically the sort of a wariness of having too much humility. So the worry is that we don't want physicians to be too humble, in the sense that they basically are just become pushovers. And we don't want them to fold as soon as a patient, for instance, demands a new diagnosis, or that they insist on having pain medication that's inappropriate for them, or whatever it is. We don't want to have humility turn into being unreflectively differential or something like that. And so Medina says that that epistemic humility is something that really should be exhibited in moderation, because attentiveness to one's cognitive limitations and deficits, well, too much of that can be pathological. It can be detrimental to your confidence and to your character. So that's why I think it's really important to be clear about what exactly humility means in the first place, and what it would look like to manifest that as it relates to patient care in general, or especially as it relates to practicing medicine and medical education in a way that is going to be anti-racist. So I think it's really important that Ho is pointing out that epistemic humility is about recognizing epistemic strengths as well as epistemic weaknesses. And so one thing is, so a patient, for instance, a Black patient seeing a physician, and that's the sort of seeing a white physician, there's that encounter has been written about extensively as being a site of epistemic violence and epistemic injustice, such that physicians tend to discount Black patients' pain. They have they see them as more likely to be doing drug seeking, or to be basically overstating how much pain they feel, and all sorts of other interactions. And so it can be a manifestation of humility, for instance, for a patient to insist, there's like, no, the pain I feel is valid, and you owe it to me as a knower to actually take it seriously. And so it can be about recognizing strength, and not just sort of everyone should be lowering themselves more. I think it's an important distinction. I think it's also really important that epistemic humility should be both self-regarding and other-regarding. So it needs to be a critical attitude towards the strengths and limitations that one has, but also what another person has. And so I think it's important for it to create space for a patient and for a physician to be receptive to a patient saying something like, well, how do you know it doesn't hurt so much? How would you have access to that kind of information? Based on what kind of thing would you be saying that contrary to my claims? And so I think it's important that it involves not just reflecting on oneself; it should also be reflecting on others as well. And so that inclination to be skeptical and to be questioning should be extending in both directions. So ultimately, I don't have all the answers for what to do here. Obviously, I think structural competency education is sort of like one sort of like off the shelf way one can do some of this, although it's only one piece of a whole. Thinking about that sort of question about sort of how do we sort of think about patients or about physicians doing patient care and medical education within the sort of larger context, I find it helpful to sort of to lean on the language that's been adopted by the population health crowd. So it's been quite popular to adopt this concept or really it's a motto of a culture of health. Insofar as I think it's going to be a hard shift for medical education to really confront racism in all of its manifestations. So it's thinking about racism as something other than just making sure that you don't give the wrong kind of tests to a patient because they are Black or Asian or something like that. So we don't want that kind of thing to happen. But if that's all we include inside anti-racist medical education, it's going to be extremely limited. And so I think it helps to I think it's important that we deal with all the different types of racism, and it should be contextualized as biological realities generated by social conditions. So again, we should be foregrounding racism and the sort of overall problem of a racist climate. So inside the population health literature, the phrasing is that we need a complete culture of health, in the sense that a culture of health includes ending interpersonal racism's harms, and thinking about the way that the structures of institutional racism, as well as the subtle horrors of things like racism manifesting inside internalization of white supremacist beliefs, that permeates an entire culture. And so basically the claim is by population health people, and I think they're right, that basically that our problems are culture deep. And so it's not just inside our interactions with each other. It's not just in the way we've structured our society. It's even inside our interactions with ourselves and our sort of self-conceptions. And so if we're going to actually make any headway on trying to actually make a healthier society, we need to deal with the problems that manifest across all of those different pathways and different forms. And so this is why we need to have a much more fulsome discussion about what racism is and how to actually practice anti-racism. So I can elaborate on any of that. And I had to do a little bit of sort of re-tinkering with this presentation in light of the last one, to avoid sort of repeating the points before too much. But I hope that sort of spurs some conversation. So thank you.